companies involved in the clinical trials and some of the new products we might see in the near future. So we'll set the stage. Some of this will be review, mainly to show everyone sort of where we are now, the standard. Of course, we all know that angiogenesis in the setting of AMD is a complicated cascade of events, as shown here, which is initiated by, not solely by, but primarily by freely diffusible VEGF, as shown here in the extracellular space, that interacts with the VEGF receptor on endothelial cells, activating, causing proliferation and exudation that we see clinically. But as you can see, there's a lot that's involved downstream in this process. But what we do now in clinical practice, of course, is neutralize that diffusible VEGF, preventing its interaction from to the VEGF receptor and blocking that process to some degree. In fact, in practice, by doing so, we can halt neovascular growth and development. We can't get regression, of course. There's limits to what that can do. Hence, the future, hopefully, is bright with other types of therapies. But in practice right now, we are doing pan-VEGF blockade with the existing highly effective therapeutics that we have in practice. That's bevacizumab Avastin, ranibizumab Lucentis, and aflibercept Eylea. Right? Those are the pan-VEGF blockades. They work very well. As you can see in practice, I'm sure you will all appreciate that for most cases of wet AMD, we can get the macula dry or nearly dry, and we can usually accomplish that within 3 or 4 injections. That's very unlike what you'll see later when we talk about DME and anti-VEGF in that setting. But it works well. We all know that. Those 3 drugs are very comparable in this setting to be able to accomplish the drying effect and the stabilization of exudative AMD. And we know, we set the stage here with regards to the gold standard clinical trials, the phase 3 pivotal registration studies with Lucentis and Eylea as shown here. We're all familiar with Marine and Anchor, followed by the VIEW studies, which are the head-to-head with Eylea and Lucentis. But we can expect, when you take all comers more or less, about an 8 to 10 letter improvement that's well maintained or sustained for at least 2 years when you're doing continuous monthly injections, or in the case of the VIEW study, the bi-monthly arm after the load. And from a proportional analysis, you can then look at what I'm going to say again is the groundwork, the gold standard of what we can accomplish with these therapeutics. And you're all familiar with this, but keep in mind, on average, about a third, even up to 40% of eyes will gain 3 or more lines over the course of therapy over 2 years. And you can count on almost 80% of eyes not losing ground, not losing any vision from baseline. Then we're moving on because from early on, we knew that that's a tremendous burden to be able to have to inject monthly to achieve those goals. So, of course, with the CAT study and the UK equivalent, the IVAN study, we then started to compare monthly therapy to as needed, individualizing therapy in an attempt not to overtreat, right? To try to find just the right number of treatments to obtain those results. But we fell short a little bit with CAT, as you see, by 2 years. The dotted lines are the PRN arms that fell a little bit short of what monthly therapy could do. PRN works well, but on average not quite as well. And in these studies, of course, in the first year, the mean number of treatments in those PRN arms were about 8 treatments, 8 to 9 treatments, and in year 2 is about 5 to 6 treatments. So with that load in the PRN style, it worked well, but not quite as well. The Harbor study, which looked at Lucentis at the standard 0.5 milligram dose and a higher dose, compared monthly to PRN. This is probably the best PRN study to date. And again, the mean number of treatments to achieve that, as you can see here listed, the 0.5 milligrams was close to 8 in year 1 and 6 in year 2. You're going to see that theme carry on, because that's really what it takes, whether it be PRN or, as you'll see, with treat and extend approaches, to get and maintain the gains that we're seeing in the pivotal studies. This is probably the best PRN study. It's sort of the most modern, if you will, and it utilized SD-OCT with patients followed monthly. Then we moved right along, and I'm sure is the case in Canada, and certainly in the United States, most retina specialists use the treat and extend approach in an attempt to sort of find the best of both worlds between monthly, continuous fixed dosing, and individualized therapy. And a lot has been published, not on quite the level 1 CAT, IVAN-like studies, but nonetheless, we see a lot that's been published through the years, and even going out 3 years or so. What you're seeing here is everything that's been published to date with ranibizumab and bevacizumab. And results are fairly consistent. 8 to 10 letters gained in well-maintained through years 2 and beyond. And the mean number of treatments it takes is about 8 in year 1 and 6 in the years thereafter. And we just published our experience using a little bit longer term follow-up here. Again, well-maintained vision using a treat and extend approach. This is with either ranibizumab or bevacizumab. Again, the mean number of treatments, as you see here, is about 8 in year 1 and 6 thereafter. So that's what it takes to maintain and get these sorts of outcomes. And this has been also validated with this smaller prospective study we just ran and presented at the major meetings, the so-called ATLAS study with aflibercept. Again, the same mean number of treatments. Why do I say all this? Because as you see, that's the burden factor. That's the reality of what we do now in practice. And there is one prospective study out of Houston, Charlie Wadkoff, Dave Brown, and his colleagues actually put for the first time the treat and extend approach to the test, a prospective randomized masked small study showing good results, very comparable. Treat and extend stacking up to monthly as shown here, but the mean number of treatments was still pretty high in order to achieve this. So with all that, what are our unmet needs? Now we'll start talking about the future. What can we do to make this situation better? Because we've made some great strides, obviously, in just about a decade now. It was the ASRS meeting just over 10 years ago in Montreal here. We first learned about what the modern anti-VEGF era could actually do. We were seeing Mirena and Anchor and what Avastin could do, but we can do better, and we need to do better because there are these significant unmet needs. So what are they? Well, we're still dealing with frequent, indefinite evaluations, injections, and again, to get good outcomes, regardless of whether it's PRN or treat and extend, it's going to take about 7 to 8 treatments in year 1 and 6 in years 2 and beyond to maintain those gains. Keep in mind that 30% of patients will lose some vision from baseline, so we can't always completely halt the progression of this disease. And we have problems with fibrosis that can sit in, the sort of patients that don't necessarily respond completely. Atrophy is setting in now that we're years into treatment. That's also compromising long-term vision outcomes. And because patients present to us already with some significant decreased vision on average, we're really looking at absolute good vision, at best 20/40 or better in about 40, no more than 60% of cases. We certainly could do better with better vision outcomes too. So one way to address these unmet needs is, at the very least, extending the durability of what we can do with our current anti-VEGF approach. So we do have a couple of new anti-VEGF agents that are currently in phase 3 clinical testing. That's abicipar and bevacizumab, and I'll show you what's the latest there. And then there's the sustained release approaches, which we've been talking about for a long time, but nonetheless, they're coming closer to reality. We have devices, there's been some work with gene therapy, and there are a variety of other platforms. So abicipar, that's a novel class of molecules called DARPins, designed anchor and repeat proteins, small binding proteins that can be made highly specific with a high degree of affinity for the target at hand. And in this case, it is the VEGF-A family of isoforms. This DARPin in particular has been shown to have a high degree of affinity, and with pharmacokinetic and pharmacodynamic modeling, it does seem to potentially give us some greater durability of effect. You can see that the half-life is about a little more than 6 days, which is a little bit better than our current therapeutics. And in phase 1-2 testing, the DARPin performance was pretty good. It gave visual results that were comparable to what we can get with our current therapeutics, but it did seem to suggest a slightly greater duration of action in the 8 to 12 week range. And that's exactly how it's being tested. It's right now in the middle of its phase 3 program. That's the CEDAR Sequoia trials, the phase 3 trials. And it's comparing abicipar dosed either every 8 or 12 weeks to the gold standard, if you will, the original ranibizumab monthly, and that's the third arm. So we'll probably be about 1.5 years away or so, depending on the speed of recruitment, till we hear about the absolute performance of abicipar. Bevacizumab actually is coming along a little faster. This is sort of like a mini Lucentis. It's an antibody fragment, but about half the size. That may work to its advantage. That's one theory here. It, of course, is a pan-VEGF-A blocker, high degree of affinity, specificity, and in phase 2 testing, they could boost the dose up to 6 milligrams, and they saw a hint of some better efficacy, although in reality, I don't think we're expecting better efficacy from this or abicipar per se, but nonetheless, that is the potential. And but more likely is by boosting the dose with this small molecule, the hope is that it will extend durability. And it's also being put to the test in that fashion to see if it will get us a greater durability of effect in the HAWK phase 3 study. This study is actually fully enrolled, it's a phase 3. So we're going to have the results potentially next year around this time. So they're looking at the way 2 doses, 3 and 6 milligrams of this drug, dosed every 12 weeks or every 8 weeks, compared to this time the comparative arm is Eylea at 2 milligrams every 8 weeks for maintenance therapy. So within the next couple of years, we'll know about 2 other anti-VEGFs that we may have in practice. What about sustained delivery? Well, there's a variety of different platforms and approaches. I'll focus on the ones that have made it farthest along, and that's the sustained release implant, the encapsulated salt technology, and some trial work with regards to gene therapy. There are others out there, others that also look promising, but just less information is known. They're a little earlier in clinical testing. You may be familiar with the sustained release device. It's also called the port delivery system. It's a collaborative effort with Genentech and Foresight Vision 4. So this is a small reservoir-like device that's implanted in the OR through the sclera, sits in place, it's not sutured. It's about 8 millimeters by 2.5 millimeters in diameter. And it's inserted in the OR, you take down the conj, you make a 3.2 millimeter incision, just pop it into place. Really goes in very smoothly and easily. Covered the conj, and it's filled initially in the OR, but it's refilled in the office through a special needle. And in phase 1 testing with 20 patients, it was pretty well tolerated. And it seemed to deliver this concentrated version of Lucentis for about 4 to 6 months or longer. So it is providing some extended duration of effect here. And it's currently right in the middle of its phase 2 test called the ladder study. And this is a 4-arm study, several different dose concentrations of Lucentis in comparison to the standard Lucentis monthly office-based injections. So we'll know a little bit more about this device over time. This is actually one of my patients in the study. We have a few patients enrolled. You can see the neat little device. That's a diaphragm that can be penetrated through the conjunctiva. Appears to be well tolerated. This is looking straight on. You really don't maybe see the edge of the device there. But again, it's about 8 millimeters long, extending into the vitreous. And that slowly releases the concentrated Lucentis. Can I go back one? There we go. You probably have seen the encapsulated cell technology. It's been around in 2 different versions. NT501 was the ciliary neurotrophic factor that was tested many years back for RP and AMD, dry AMD. But the NT503 is the latest iteration. These are genetically engineered RPE cells in this semi-permeable polymer capsule that's designed to release an anti-VEGF molecule. It's actually a VEGF receptor fusion protein. And in preclinical testing, it was able to express this protein, the therapeutic product that is, for 2 years or more. So it looked promising as a sustained release device. This is more like a Retisert implant. You go to the OR, make the incision, pop it in, and then suture it in place, as shown here in the diagram. And it was very sophisticated technology. The semi-permeable membrane allows for the outward diffusion of the drug and the inward diffusion of the nutrients necessary to keep the RPE cells alive. And it did show some promise. It entered a phase 2 study early on. We were one of those centers. And the way it worked is that you put it in place and then you do rescue therapy if you don't see a sustained effect. And unfortunately, early on in the study, there were too many rescue therapies needed. So it didn't appear as though the drug was delivering enough or high enough concentration of the therapeutic anti-VEGF molecules. So unfortunately, the study was halted at phase 2. So some work needs to be done to figure out what's going wrong and why the device is not yielding sufficient drug. What about gene therapy? Now, you may remember there were 2 sort of competing technologies originally. There was an attempt to go intravitreal with gene therapy. Company Genzyme tried that, but they weren't getting good enough, again, the therapeutic product, the anti-VEGF. It was SFLT1 is the anti-VEGF molecule that we're dealing with here. So Avalanche, the other company, utilized the surgical vitrectomy subretinal injection approach. and that seemed to be working pretty well early on, at least in preclinical testing. So what you have here is the therapeutic DNA. That's the S-FLIP1 plasmid in solution, the adeno-associated virus vector, and then injected it with a translocation cannula in the subretinal space after a limited vitrectomy. And that was put to test in phase 1. It's a very small phase 1 testing that was conducted in Australia. You can see the study design here. There are only 3 patients in the 2 low and high dose arms respectively compared to the control arm. But nonetheless, the way that this is designed is that a couple of injections up front to get the disease under control, and then the surgery in between those injections needs a little time to ramp up, theoretically, to get the product, which should be indefinitely sustained. I mean, you're talking here the potential for truly sustained delivery, indefinitely, for years. So that's intriguing. And so this is, again, the results from that limited small phase 1, which showed very few rescue treatments in the eyes that had the gene therapy compared to control and then historical control. So it looked promising in that phase, very small phase 1. But the phase 2A study, which is an additional 36 patients, showed some mixed results. It did seem as though it was working well in some patients, so sort of two sort of bimodal in terms of the results. You can see patients here actually did very well, vision improved, well maintained on very few injections, and the mean number of rescue treatments were different, meaning less in favor of the gene therapy. But unfortunately, there are also a fair number of patients that got gene therapy that needed a lot of rescue therapy. So sort of like the NT501 problem, 503 problem, too many rescue therapies were needed, indicating, of course, that the effect was not good enough and not well sustained. So this unfortunately put a pause to the program. It was supposed to enter phase 2B by now, but it's taken a step back. And they're doing some preclinical work to try to figure out the problem. They may even suggest going back to an intravitreal approach. I think it's just a temporary delay. I think there's probably going to be some gene therapy-like application in the future, one way or another. But what about beyond VEGF? As I mentioned before, there's a lot of other potential targets here in the cascade of events that take place with neovascular growth and development. We see all the different direct-acting anti-VEGF approaches that we've talked about, but you've got all the downstream receptors and beyond and other growth factors that probably do play a role in conjunction with VEGF. So everything listed here is a therapeutic that is either in testing or has been tested to date. And probably on the top of the list and furthest along as a target is platelet-derived growth factor, or PDGF inhibition. Platelet-derived growth factor has been shown to be important in terms of cell regulation, growth, division, with some pericyte recruitment. That's what it's doing. It's allowing for the maturation of new blood vessel growth. And so blocking PDGF prevents pericyte recruitment and essentially destabilizes a neovascular complex. Another way to put it is it's thought to make the neovascular complex potentially more anti-VEGF sensitive. So they seem to complement, at least that approach is potentially complementary. And there are 2 therapeutics out there. Further along is the anti-PDGF aptamer, known as Fovista or pegclarinet. That's in phase 3 testing. So that binds one of the principal PDGF molecules. And the other is the ranibizumab. That's an anti-PDGF receptor monoclonal antibody. Now that just completed, and you probably are aware that just a few weeks ago there was a press release with the top-line results to its phase 2 study. It was found to be ineffective, which it was quite surprising. And frankly, sort of threw a wrench in prospects for this drug. But nonetheless, you can't get around the fact that a very strong, large phase 2 study called the REGRESS study was conducted with the anti-PDGF aptamer, Fovista, which showed very promising vision results. Now the hope here is that we're not talking about extending durability of anti-VEGF, we're talking about potentially better vision outcomes, and that's exactly what phase 2 showed in a dose response, as you see here with the high dose combination better than the low dose combination, better than ranibizumab, and you can see a nice clinically meaningful degree of added visual acuity benefit. So this is now in phase 3 testing, and in fact the phase 3 test is so far along, it's in the data analysis stage. So we're going to know the results of anti-PDGF in the form of the aptamer blockade within the next few months. So we'll know if we have something new or different than anti-VEGF very soon, potentially by the end of this year. What about squalene? This molecule has been around a while. In fact, that was one of the early testing sites when it was initially tested for wet AMD by intravenous infusion, but it wasn't well tolerated. It's a small molecule, immunosterile molecule that works intracellularly, potentially here downstream, inhibiting a variety of growth factors in addition to VEGF. But there's a new formulation after the intravenous approach was not well tolerated to go topical. And they've demonstrated some good topical penetration. So that's called the OR-102, and that's a twice-a-day drop is how it's being administered in clinical studies. And there was some very early excitement with an interim analysis. The interim analysis was half of the study population showing some benefit in the combination arm. Actually looks very similar to the Fovista outcomes here. You can see the added visual acuity improvement compared to Lucentis monotherapy, and equal number of treatments, anti-VEGF injections were delivered. So this is twice a day drop versus placebo-controlled drop there, and that got everyone pretty excited that we were on to something that's also pretty effective. But unfortunately, the complete cohort analysis didn't quite show the same magnitude of benefit. It showed a little bit of benefit, wasn't really statistically significant, but they looked at some subgroups and saw some promise with the smaller occult lesions and the classic-containing lesions. So they thought that's where it's potentially most beneficial. They went ahead and now it's in phase 3 testing looking at those subgroups. What about ICON-1? This is a very unique and sort of different type of molecule, target, and approach. ICON-1 is a recombinant fusion protein that's designed to target or bind tissue factor. Now, tissue factor is not something that's freely diffusible, but it's expressed on the surface of proliferating blood cells. And so what's happening here is the molecule is potentially binding to the tissue factor on the surface of the endothelial cell as shown here. And what that does is elicits an immune response, a cellular mediated immune response. Natural killer cells are recruited and cell death occurs. So this is true targeted immunotherapy. And it's being actually looked into not only for wet AMD, for also intraocular melanoma, and some trials in that arena may start up soon. In phase 1 testing, a very small study, and it showed some biologic signal in terms of some potential benefit. It was just a single administration, varying doses of the ICON-1 molecule. This is an intravitreal injection, and I'll tell you that's certainly not natural history. Baseline week 5 after 1 injection showed something that seemed to be beneficial as shown by OCT and fluorescein angiography. So that's actually fully recruited into phase 2, the so-called Emerge study. It's a 3-arm study looking at ICON-1 intravitreal injections monthly as monotherapy, as combination therapy with anti-VEGF compared to anti-VEGF alone. We're going to have the results of this. I may be the one to present this at Angiogenesis in February, so stay tuned. We might have something else that looks promising. And then there's the rather complicated angiopoietin pathway, the angiopoietin Tie2 receptor molecule axis, if you will. It's rather complicated, and I'm not sure clinicians like myself fully understand this, but the Tie2 receptor works in conjunction with VEGF, in essence in apposition to some degree to control the avascular growth and development. But simply put, Ang1 is an agonist to stimulate or upregulate the activity of Tie2, which is favorable for vascular stability. Ang2, angiopoietin-2, works as effectively an antagonist, which inhibits Tie2, which in turn allows for the proliferation for angiogenesis through VEGF stimulation. So the approach here, you can either upregulate or stimulate Tie2 directly, and there is a drug, a therapeutic out there that's being tested, but here in the wet AMD space, there are 2 Ang2 inhibitors that are now currently being tested in hopes that in combination with anti-VEGF, they'll yield added benefits. The Onyx phase 2 study with Regeneron is a co-formulation of an anti-Ang2 antibody in combination with aflibercept, and that's in phase 2 testing right now. And then Genentech has this rather unique bispecific molecule. It looks like a full-length antibody with the Fc portion that's been deactivated. And one arm is to block or bind VEGF, and the other arm is to bind Ang2. That's also in phase 2 testing. That's the Avenue study. As I mentioned, there's a variety of other potential targets and approaches, and a lot of what you see listed here are intravitreally administered, but there are a few exceptions to that. A couple of topical preparations here, these two kinase inhibitors. There's also an oral administered kinase inhibitor, dual-acting kinase inhibitor called X82. Everything else there is more or less intravitreally administered, and a lot of it is not panning out, unfortunately. Crossed out are things that have already gone through phase 2 testing and shown to be ineffective. So I don't think we'll be talking anymore about bioactive lipids. Kinase inhibition, still alive and still in testing. Radiation, effectively dead. A variety of other approaches that we'll probably hear more about in the near future. So obviously, wet AMD management is involved greatly. Probably effectively started here with results of modern anti-VEGF era therapy in the clinical studies. The current approach is, of course, neutralizing VEGF in practice. The best we can do is pretty frequent administration up front and relatively frequent administration thereafter to keep on top of the disease. It's highly likely we'll have at least another direct-acting anti-VEGF agent in the next couple of years that may or may not add much to what we're doing now. Hopefully in durability it would. Sustained release, it's coming in some form or another, whether it's 3 years or 5 years, probably more of a 5-year like time frame. And then there's a variety of other targets. We could have an anti-PDGF, anti-Ang2, anti-tissue factor within the next 3 to 5 years. Before concluding, I just want to make a point about going back to where we are now, because I outlined the unmet needs, but I want to stress something that actually hasn't really been talked much about, which is the importance of early detection. If right now, and if in the near future all we have is anti-VEGF, we have to try to utilize these drugs in the most effective way. And getting the best results means catching wet AMD early. And I want to show you some results of some work that points to the power of early detection. Every study in wet AMD, even going back to photodynamic therapy, points to the importance of better outcomes with smaller lesions at baseline, as shown here. In the CAT study, this analysis, eyes with small lesions tend to have better vision at baseline and have even better vision gains over time. That shouldn't be surprising. But when it comes to absolute vision, what the patient sees, not how much letters they gain, but in the end, at the end of the day, of course, it's how good is your vision. And if you start off good, you end even better. And so this patient's a lot happier than this patient, even though they got less gain. But nonetheless, if you start off with good vision, you're going to typically end with good vision. We just published in our Treat and Extend database, we looked specifically at eyes that presented with 20/40 or better vision. And after 2 years of treatment, we could keep them 20/40 or better up over 75% of the time. So that's a powerful thing when you really think of it. And there's ways to detect CNV earlier. We can utilize technologies that are coming or that are available now to be able to detect CNV at its very earliest small stage. When the vision's good and when the lesion's small, we can get excellent results even with just anti-VEGF alone. So why are we troubled when we see this? This is the 5-year extension follow-up data to the CAT study, and it's pretty depressing when you look at it because we see the great visual gains year 2 in the protocol of the CAT study, and then not only loss of the gains, but these patients are actually seeing worse than when they started. That's 3 years after exit from the study. There's a fair number of patients. So why did this happen? Now, a lot of people are pointing to atrophy, the inevitable atrophy that we can't treat as the reason. But in reality, atrophy is a small component of this. Yes, we see that in practice. I'm sure you all have patients that are 5+ years into getting anti-VEGF and losing some ground on the basis of atrophy. It's true that atrophy, significant atrophy, was detected in close to 40% of patients by year 5, but subfoveal or center involving atrophy was only 17%. So that doesn't account for all this vision loss. The fact is that there was a 50% growth in CNV size from year 2 to year 5, and the majority of patients had still signs of active exudation at year 5. and the mean number of treatment was only around 4. 4 doesn't cut it when you're talking about average. So unfortunately, this represents a lot of under-treatment. So if you really want to get good results for wet AMD, what we have now, whether or not we make any significant gains and have some new therapeutics in the near future, you have to be on top of the management. You have to keep the maculas dry and the CMV process suppressed as best as possible over time. And to get the best vision results, you need to detect CMV in its smallest, earliest stage. Thank you very much.